Hi, all, and welcome back to Professor Truelove's Concepts for Nurses series. This is Professor Terry Truelove, and this episode is the first of two dealing with ventricular arrhythmias, including premature ventricular complexes and R-on-T phenomena. Sources for this episode include Cohn's Flip&C ECG, 4th edition. What are ventricular arrhythmias? Ventricular arrhythmias originate in the ventricles below the bundle of His. They depolarize the myocardium using a different pathway from normal impulses. This means the ventricles will depolarize in a different direction than normally found in a healthy heart, and the atria, if they depolarize, will depolarize after the impulse comes to it from the ventricles. Because of the barrier of the AV septum, that impulse may never impact the atria. And because of this, the T wave and the QRS complex are going to deflect in opposite directions, and the P wave will be absent. Impulses from the ventricle occur because of a number of different reasons. If the SA node or the other atrial pacemakers and the AV node fail to fire, the ventricles should fire, and this is known as ventricular escape beats, or VEBs. Also, under certain irritating conditions, such as lack of oxygen, incorrect levels of electrolytes, especially potassium, the ventricles might fire early. If the ventricles fire early, these are known as premature ventricular complexes, or PVCs. In this example, we see a premature ventricular complex. Note the different looking QRS complex, which is sometimes referred to as wide and bizarre looking. Also note the lack of a P wave. And lastly, note how the QRS complex, particularly the R wave, occurs before the next expected, normally conducted QRS complex should have occurred. You may hear PVCs referred to as premature ventricular contractions. This is improper unless we're actually feeling for a pulse and we are looking at the electrical activity at exactly the same time. Otherwise, we don't know if a mechanical response follows the electrical impulse. So, premature ventricular complex. It does have a wide and bizarre appearance because the impulse has to travel farther to reach the entire heart. Remember, these are outside of the pathway, so it's going to take a longer amount of time for the impulse to reach the entire heart. That will prolong the QRS complex, and it occurs before the next expected QRS complex. Causes of PVC include drug intoxication from such agents as cocainamides, amphetamines, and tricyclic antidepressants. Other causes include enlargement of the ventricular chambers, increased sympathetic stimulation, myocarditis, caffeine or alcohol ingestion, the pro-arrhythmia effects of some antiarrhythmics, and tobacco use. When the reader looks for a PVC on the rhythm strip, they should look for a QRS that is greater than 0.12 seconds, that is, wide and bizarre. So the QRS will look different than normal QRSs. If the PVCs look all of the same, this is called unifocal, and this means that the origin of impulse is from one area. If the PVCs look different, this is multifocal, and this means the origin of the impulses are from multiple areas. In the example above, you see that the PVCs all look the same, unifocal PVC. However, on the bottom strip, the two PVCs look different, indicating that the impulses are coming from different areas. We should call this multifocal PVC. Chemical imbalances that cause PVC include electrolyte imbalances such as hypokalemia, hyperkalemia, hypomagnesemia, hypocalcemia, metabolic acidosis, hypoxia, and for non-chemical reasons such as myocardial ischemia and myocardial infarction. PVCs show irritability in the ventricles, and that can lead us to two really big problems, both of which have potential lethality. The presence of PVC may lead up to more lethal, more serious dysrhythmias, and the PVCs themselves, well, if they're frequent enough, will decrease cardiac output. The decreased cardiac output is a result from the loss of atrial kick and the loss of proper ventricular filling time. On the rhythm strip, the reader would look for a QRS complex that looks wide and bizarre and appears as early beats, causing atrial and ventricular irregularity. The P wave is usually absent. Retrograde P waves may be stimulated by the PVC and cause a distortion of the ST segment. And the PR interval and QT interval aren't measurable on this premature beat. PVCs may prove dangerous to your patient if there are more than one PVC that occur in a row. These are known as couplets, triplets, salvos, or runs for longer strings of PVCs. Multifocal, or PVCs that occur from more than one foci, are also considered dangerous, as are PVCs that occur every second or third beat, that is, bigeminal PVCs and trigeminal PVCs. Lastly, PVCs may cause lethal ventricular arrhythmias because of R-on-T phenomenon. R-on-T phenomenon occurs when the R wave of the PVC falls precisely on the T wave of the previous complex. This sets up a feedback loop where the impulse simply circles around over and over and over again within the ventricles, part of the ventricles being repolarizing while the other parts are depolarizing. This may lead to such lethal arrhythmias as ventricular tachycardia or ventricular fibrillation. With any rhythm, we do not specifically treat the electrical activity. Instead, we look to see how it affects cardiac output, and we treat the patient according to hemodynamic instability. We have reached the end of this episode, but hang on. There is yet another episode devoted to ventricular dysrhythmias. As for this episode, I do hope you learned a little bit. I hope you plan on coming back to watch more, and if you do, we'll see you then.